We just discussed about family medicine in Cyprus, and there was a thought that people who do family medicine can sit for the diploma of the Royal College of Obstetricians and Gynecologists. So we had some communication with the Royal College, which doesn't allow people outside the UK to do the exam. There are some stipulations about General Medical Council recognition, and they have to be in the UK and so forth. And we are trying to break that mold. So it was good that the RCGP came here and gave the assessment. So I sent that across and said, if the RCGP says that they can do it, why can't you do it? And so they said, okay, they'll be able to allow doctors who are doing the family medicine curriculum in Cyprus to do the DRCOG. Now the question is, do we need the DRCOG? So I'm going to make a plea for women's health rather than whether you want to do the DRCOG or not, but it's a good idea to know the substances within the DRCOG syllabus to have that. Now this is actually in the college website. These are altogether 7 modules, as you could see: basic clinical skills, surgical skills, antenatal care, labor and delivery, not that people are going to do that, but to have the knowledge about that. Postpartum problems is quite important, including neonatal, gynecological, fertility control. Now, under each of these subset of modules, there are a number of criterion here, as you could see here. I won't go through that in detail, but it's in the website. So the important thing I have underlined or marked in red, it is actually to understand the patterns or symptoms of gynecological problems, sexually transmitted, the issues with family planning, to have an understanding of the pathophysiological basis, then to have effective verbal and non-verbal communication, ethical and legal issues, which will vary from country to country, and medical confidentiality, and about consent in all clinical situations. So it's a general module which will be also covered in the other areas. We go to basic surgical skills. Of course, we don't expect family practitioners to do surgical procedures, but really to have an understanding of the commonly done obstetrics and gynecological procedures, because family medicine practitioners should be able to explain what it is all about and also provide some reassurance and also some idea about infection, the commonly encountered like thrush and trichomonas and so on and so forth, and also post-operative, so pre-operative and post-operative care. That's about the second module. Third is about antenatal care. That is practiced variably in the UK. The midwives are sometimes based in the general practice, and generally to understand about the standard of care, sometimes shared care between GP and the hospital, or GP midwife and the hospital, but also to have a little bit better understanding about other things involved, like domestic violence, emotional issues, common medical disorders, for example, epilepsy and diabetes. If they're not picked up, or psychiatric disorders, if they're not picked up by the family practitioner, then it goes completely unaware of the hospital, and when they break down, then only the time they pick it up. Some idea about therapeutics and also about antenatal screening. So not that people have to do, but just some idea about then labor and delivery. It's actually about initial management if there's a problem, but mainly about what happens in the hospital, and about appropriate knowledge of anesthesia, and about cultural differences, and postpartum, mainly about postpartum maternal problems. Breastfeeding is quite an important one, and also if there is immediate neonatal problems, so that will be also tackled. But psychological disorders and breastfeeding is the key issues. Gynecological, quite a lot, because as John showed, about 80-90% of the problems can be tackled in the family health physician's clinic. Benign gynecological and pediatric and adolescent gynecology, endocrine problems, abnormal bleeding, early pregnancy loss. Ectopic, of course, they have to go to the hospital, but an understanding when to refer. And commonly sexual transmitted infection and contact tracing. Sixth is about, again, gynecological national screening programs, well, and what is available in terms of pap smears and the breast examinations. Subfertility, and also about some knowledge of assisted conception, and quite a number of things. Investigation can be done in the primary care setting rather than sending them to the hospital. Fertility control, of course, Cyprus, it will be differing in terms of termination of pregnancy regulations. But in the UK, we ask them to have the knowledge and management skills of fertility control. Contraception is quite an important one, but reversible and irreversible methods and the knowledge and so forth. So these are actually the 7 modules in a nutshell. But I'm just going to really emphasize the need why we had to focus on these. If you take a girl, you can talk about various things from smoking, alcohol, substance use, mental health, postmenopausal health, adolescence, eating disorders, reproductive health, and so on and so forth. Now you can put that in a life cycle course, and we have divided that into education part because the family physician has a major role in educating, and also about what the conditions depending on the age group. So early, the childhood is vaccination, HPV vaccination, chlamydia screening when they go into adolescent. Then when they are in the reproductive age group, sexual health, contraception, pregnancy care, assisted conception, screening, heavy menstrual bleeding. Then they go to the menopause breast screening, and also incontinence and prolapse problems comes as a major issue. So it's actually not that you can really do a lot by educating and trying to get them. So I'll just go through very quickly about adolescent health and eating disorders, teenage pregnancies, reproductive tract infection, mental health issues are quite common in adolescents, and we should be able to provide targeted services. Obesity is quite an issue, which is causing a major problem in most countries, and the best time to tackle is from childhood to adolescent. And these are quite a lot of things you can think of avoiding, and also they have impact on the reproductive health. So the family physician in many ways in the key position because they see the child from early onwards. They come to the same doctor, so you can talk and advise about the impact of obesity on quite a lot of things, and you should be able to have some idea and also to discuss and debate. So this is quite a number of things. Anorexia is again major issue and major impact by social media. And if we can really, if the parents bring sometimes or they themselves say, then they have to be tackled. And healthy eating is something which can be emphasized from early times to avoid both problems about obesity and anorexia. I call it the 4-square plate here. You take a plate and put greens on one side, the meat or fish on one side, the carbohydrate, and the fruit. So that's all. But also tell them to have only 1 serving, not to have 3 servings of this 4 plate. That'll be too dangerous. And there are 7 S's I talk about. Is actually things which are not good: salt, sugar, smoking, saturated fatty acids, and alcohol, and so on and so forth. So I think it's something advised. Now, osteoporosis, sometimes it's too late when they're coming at the climacteric menopause, because from the early days, if they are on high salt intake, caffeine, smoking, and animal fats, then in many ways that's the one which cracks, and they don't form good bones. So obviously, when they get elderly, then it runs into problem. And it's quite important. 40% of the bone is during the adolescence, so they must have milk and cheese, and it's quite important to really tell them not to wait till the last minute. So really, John showed us a slide about promoting health, or are we treating disease? And I think in family practice we have to do quite a lot on promoting health, and it's the best opportunity. HPV vaccine, which is to prevent cancer, except today's news says that women are running into trouble in Colombia or somewhere, that adolescent girls have been brought into hospital with some syndrome. Just 5 o'clock news today. But this is, it has been used on millions now, so it's not a problem, and that is something to do. Now, if you go to reproductive age group, then subfertility, contraception, heavy menstrual bleeding, and pregnancy-related issues, to have knowledge and to help the women actually at that stage. And we can talk about some idea about basic investigations and when to refer the patient beyond. Because nowadays, quite a lot of things are happening, even freezing the egg and so on, and women are getting married at a later stage. But the basic investigations, by taking a history, giving advice, or weight reduction, and doing that can be done. When they're in pregnancy, of course, before pregnancy, you can talk about folic acid, rubella, a pre-existing medical condition. It's quite important to do that. And in pregnancy, if you're doing shared care, which is quite important to have some idea to share the care. So that is something. Of course, when you refer to the hospital just to make sure that the baby is doing well, this is just to show some scans, calipees and ovarian cyst and so on. Like an only scan, they do it 20 weeks to show that lip is okay and is all right, fingers and spine and so on and so forth. So we don't have to really go into any details, but many other lesions can be picked up quite early, by 12 weeks, and nowadays booking scan is quite an important one. And there are a number of therapies which are available to treat them in utero, like constructed bladder or kidney and so on. So I won't go into the details, but anything they find as abnormal, they should be able to really show, and they can treat many of these conditions. Quite a large number of conditions can be treated. Now, once they have finished the reproduction and the baby, and one of the common problems they come with heavy menstrual bleeding. And the NICE guideline says quite a vast number of women, 60 to 70%, can be managed by just medication and improving the hemoglobin level, and medication is the mainstay. But sometimes if it is excessive, they might have some simple therapy. Nowadays they can put a balloon and just put some hot water, which is a special machine. You can do an endometrial ablation. Or if it is a small polyp, they find they can resect it. And it is, of course, very rarely you might come across such a situation. A woman comes and you pick them up and send them with a large fibroid, and can reconstruct them, and they will do well. So benign conditions to identify and send in the appropriate group is one of the areas. Otherwise they keep on coming again and again. Contraception, there is quite a lot. I'm just showing a copper T here, which lasts for about 10 years. So if the woman is 35, we put it in, and she don't need any further contraception. A good knowledge of contraception helps a lot, and sometimes it is really the myth and misunderstanding you have to get across. I mean, because people hear some stories that if you are coiled, there'll be infection, there'll be bleeding, there'll be and so on and so forth. So that is where it comes. And generally, long-acting reversible contraception, they use a typical use, and the failure rate is very, very low compared to condoms, bathrooms, and so on and so forth. So something which is worth considering. Now, coming to age, so once they have come past the productive age group, we come to age, which is really climactic and menopause. And I did some studies with Bruno Riemann field just to show that the population is aging, and when we talk about developed and developing countries, the life expectancy is on the increase, and this is in developed countries. Males a little bit less compared to the females, 72 to 81, and developing countries a little bit less. But the pattern is something which we have to recognize, because in the world at the moment there are nearly 550 million over 65 years, but in 2050 then there will be 2 billion people. So that will be distributed throughout the world. And if I don't know about Cyprus, and we talk about those who are over 80 years, they are about 69 million, and that will be about 339 million. So in years to come, this is going to be a huge burden. And if you look at the life expectancy in the 1860s to 1998, what happens is if you had birth, your life expectancy was 32.7, and at that time now it's 74. But when you had 1, then it's 74. And when you're at 75, you have another 9 years to go. I mean, it's about 84, 85. And women, it's the same thing. And as you can say, that women's life expectancy is much greater than the men's life expectancy at any one age group. That's why it's quite important about women's health. So what if they're getting old? What is the problem? And why are they growing up old? Because we have tackled all the communicable diseases in a big way. I mean, these are various people who have contributed about hand washing, sanitation, sewage, vaccination, quite a lot of things, antibiotics. So we have tackled quite a lot of things which people used to die. So people are living for a longer time with aging, and the family physician has to be the guardian because if you can imagine that after climacteric about 50, 52 years, if they're going till 85 or 90 years, they're nearly another 40 to 50% of their life, and at that time they have major problems: hot flushes, urinary symptoms, vaginal dryness, osteoporosis, fractures. Now, none of these really need to go to the hospital. The family physician can look after these things. And with age, there's a rising incidence of cancers. So cancer screening, what we can do, degenerative conditions, cardiovascular. And the most important thing is actually the major illnesses towards the end of life. So although we say life expectancy has increased, you have to put inverted commas, healthy life expectancy. That means if they go into Alzheimer's or frailty, they can't move, it is not a healthy life expectancy. So we have to really reduce that period of frailty, both mentally and physically, and incapacity for self-care. This is actually just like a map. You can see the communicable diseases are mapped out, which people used to die early, adult life, and they go on. 2011, as you could see, earlier people didn't live long to get the disability conditions. Now they are living to areas of frailty now because of that. This is a gradual improvement in what happened: antibiotics, vaccination, lifestyle, and non-communicable diseases. Now in Europe, actually, as you could see, if you compare countries, there's a vast discrepancy. If you take Russia, for example, at the bottom, women and men, about people who are dying before the age of 60. In Russia, nearly half of them die before the age of 60. And mainly it's alcohol and violence and accidents and so on. Whereas women, about 19%. I couldn't see Cyprus here, but probably we'll pitch it along. Greece might be an equivalent picture to only at 12%, which is good. But this can also be improved to a greater degree. And this is again comparing male versus female, as you could, life expectancy. And here I put healthy life expectancy at different age group. And the females are going to live longer compared to the males, as you could see here. So you have to really reduce that period where the minus sign is there by careful strategies. This is the area of frailty, and can you really chip it off and make this block even less? And that is where I mentioned about the early nutrition and adolescent, about milk and cheese and good food and nutrition and so on, and screening to help it. And not only it's gynecological, but also bowel cancers are not an uncommon thing in addition to the breast cancer. So you have to advise on dietary factors which can reduce, and also if necessary, you can arrange for screening. And colonoscopy is supposed to be the best if they have any symptoms, because in Britain that they use occult blood test, which is sent as a slide for us to put a sample of stool and send it. But it only picks up about 17% of the cases, whereas colposcopy the colonoscopy seems to be far better in terms of picking up lesions. Cervical cancer, I don't have to tell you much. Of course, if they had done 3 or more pap smears and all have been negative till the age of 60, we don't do it anymore. But if there's any issues, then you have to do that. Breast cancer, self-examination, examination by the family practitioner, and also routine screening, because usually it can start as ductal carcinomas, which are not easily picked up with the examination. So it's actually mammography every 2 years. And if they've got problems like BRCA1, BRCA2, how can we really reduce them? And there is in the early age, they can put them on some medication, which will be like endometrial cancer. Again, there are issues when there is warning them of what can happen. And also, if they have been infertile, then they have a higher chance of getting this, so they have to have more regular screening in some cases. Osteoporosis, I mentioned to you. And densitometers, bone densitometers can be bought in a big practice, and you can do that without sending them to the hospital. Vitamin D deficiency is also considered a major factor in old age. They don't go out, they don't get much sunlight. And also for sarcopenia, cardiovascular as well as sarcopenia, this is muscle wasting, is supposed to be more common without this vitamin D and calcium, so it's important. So frailty is something we are trying to avoid, and nobody else can do it other than the family practitioners by seeing them from very early days and giving them advice. And also to in the house, one of the common problems is the fall. And a simple thing like holding a chair, sitting and standing, or squatting and standing, or some exercise will help in terms of the strength of the muscles, because most of the time you put some bars in the bathroom and on the entrances because they are not very steady on their legs, so they have to hold on something. But if you can build their strength on the legs, then the chance of falls and hospitalization and disability to death can be prevented. So it's quite important about these exercises, promoting exercise. And in China and Hong Kong and so on, if you go in the grounds, they have this Tai Chi, they are having poses and somebody is showing the exercise and they are doing. So it's quite important that in adults there are quite a number of things: cardiovascular, diabetes, cancer, arthritis, and so on and so forth. And to prevent frailty is most of the important things. Aerobic flexibility training and exercise training complemented by cultural activities. Social activity is again quite important to prevent them having mental issues. So just to summarize, actually, the 20th century is the population growth. 21st century will be the century for aging. So although we are going to look after them, our workload is going to increase tremendously for family practitioners, for prevention and looking after these age-related illnesses have to be tackled, like hypertension, like diabetes, and so on and so forth. So really, I would like to say you should be the guardian of women's health, because nobody else can do that. And education and training in this area will certainly help you to achieve that. So thank you very much.